Here's a question almost nobody asks after a doctor's appointment. What actually happens to your blood pressure the moment you stand up? Not while you're sitting calmly in that exam room chair. Not during the 60 seconds the cuff is wrapped around your arm while you're relaxed and still. What happens 3 seconds later when you swing your legs off the table, stand up, and walk out the door? For a huge number of older adults, that's the exact moment when something important gets missed. And it's not because doctors don't care, it's because a single-seated reading, taken once every few months, simply can't capture what your blood pressure is doing throughout your actual day. Standing up from a chair, getting out of bed at 2 a.m., walking to the mailbox. These are the moments that matter most for fall risk, dizziness, and long-term cardiovascular health. And they're almost never measured in a routine visit. By the time you finish this video, you're going to understand something most people don't, that a good blood pressure number on paper doesn't always tell the full story, especially as we get older. You'll learn about a simple 2-minute test you can do at home tonight that many routine appointments skip entirely. And you'll walk away with exactly the right questions to bring to your next doctor's visit, questions that could genuinely change how your treatment is managed. This isn't about second-guessing your doctor. It's about giving you the information to have a sharper, more specific conversation with them, because the more detail you bring to that 15-minute appointment, the more your doctor can actually do with it. Let's start with the basics, because you need this foundation before anything else makes sense. For decades, the guidance around blood pressure has been fairly uniform. Lower is better, and a 120/80 has been held up as the gold standard to aim for. And for a large portion of the adult population, particularly younger and middle-aged adults without complicating health conditions, that guidance holds up well. Large clinical trials have consistently shown that bringing blood pressure down into a healthier range reduces the risk of heart attack, stroke, and other cardiovascular events. This isn't in dispute. But here's the nuance that often gets lost by the time this information reaches a patient in an exam room. As we move into our 70s, 80s, and beyond, the body's relationship with blood pressure changes in ways that are worth understanding. Medical researchers and geriatric specialists have increasingly emphasized that treatment targets for older adults need to account for more than just the number on the chart. They need to account for the whole person, their other health conditions, the medications they're already taking, their kidney function, and critically, their risk of falls. This is actually reflected in current medical guidance. Major cardiology and geriatric organizations already recommend that blood pressure treatment for older adults, especially those who are frail or managing multiple health conditions, should be individualized rather than chasing one universal number. That's not a fringe idea. It's part of mainstream clinical guidance today. The challenge is that this nuance doesn't always make it into a quick appointment, and patients often walk away simply knowing my numbers are good without understanding the fuller picture behind that assessment. So let's talk about why the body changes as we age, because this is the part that actually explains everything else. Think about the difference between a brand new garden hose and one that's been sitting outside for 20 years. The new hose is flexible. It gives a little when water pressure moves through it, absorbing some of that force. The old hose has lost that flexibility. It's stiffer, less forgiving, and reacts differently to the same amount of pressure. Your arteries go through something similar over time. As we age, the walls of our blood vessels naturally lose some elasticity, a process often referred to as arterial stiffening. This is a well-documented part of the aging cardiovascular system, and it changes how your body handles blood pressure moment to moment, particularly during position changes, like standing up. Alongside that, there's a second mechanism worth understanding: the body's internal pressure-sensing system. Scattered through your blood vessels are tiny receptors called baroreceptors, and their job is to detect sudden changes in blood pressure and signal the heart and blood vessels to adjust almost instantly, for example, the moment you stand up and gravity pulls blood toward your legs. In younger adults, this reflex is fast and precise. As we age, research shows this reflex can become slower and less sensitive, meaning the correction doesn't happen quite as quickly. That gap, however brief, can be exactly what causes that lightheaded, dizzy feeling when standing up too fast. And there's a third piece. How the body processes medication changes with age, too. Kidney and liver function naturally shift over the years, which can affect how quickly blood pressure medications are metabolized and cleared from the body. A dosage that was well calibrated at one point may behave differently years later, simply because the body is processing it differently now. Put these three things together: stiffer arteries, a slower internal pressure correction system, and changing medication metabolism, and you start to see why a single good seated blood pressure reading doesn't automatically guarantee everything is fine the moment you stand up. This combination of a blood pressure drop upon standing has an actual clinical name: orthostatic hypotension. It's a well-recognized, well-studied condition, and it becomes more common as people age, particularly for those managing high blood pressure with medication. The concerning part isn't the name itself. It's how often it goes undetected, simply because it requires a very specific kind of measurement that isn't always part of a routine check. Here's what makes this especially worth paying attention to. The symptoms of orthostatic hypotension are incredibly easy to dismiss as just getting older. Feeling briefly dizzy when standing from a chair, a moment of lightheadedness getting out of bed, a sense of unsteadiness that passes after a few seconds. These are exactly the kinds of symptoms that tend to get mentioned briefly in an appointment and then folded into general advice like stand up slowly, without further investigation into whether blood pressure itself is the underlying cause. And that matters, because when it is the underlying cause, it's genuinely addressable. This isn't a mysterious, untreatable part of aging. It's a measurable physiological pattern. And once it's identified, there are concrete steps a doctor can take, whether that's adjusting medication timing, reconsidering dosages, or simply keeping closer track of it over time. So here's where we're headed for the rest of this video. I'm going to walk you through exactly how to check for this at home tonight, using nothing more than a basic blood pressure monitor you can find at almost any pharmacy. I'll explain what the numbers actually mean once you have them, and I'll give you the specific, practical questions to bring to your next doctor's appointment, the kind of questions that shift a conversation from "your numbers look fine" to a much more personalized discussion about what's actually happening in your body day to day. Because here's the truth. Your doctor genuinely wants this information. Most physicians simply don't have 15 extra minutes in a standard appointment to run through a full orthostatic assessment on every patient, every visit. But when a patient walks in already having done that check at home, with real numbers in hand, it transforms the conversation. It gives the doctor something concrete to work with instead of a vague mention of, "Sometimes I feel a little dizzy." If you've ever felt that brief head spin when standing up too fast, or if you're caring for a parent or older relative who has mentioned something similar, stay with me, because what comes next could be one of the more practically useful 2 minutes you spend all week. We're going to walk through exactly how this test works, what your results actually mean, and what steps typically come next. All right, let's get into the practical part. The actual test, step by step, because this is the part you can genuinely use tonight. Here's what you'll need. A home blood pressure monitor, the kind with an arm cuff that most pharmacies, grocery stores, or online retailers sell for a reasonable price. If you already own one, even better. If your household doesn't have one, this is genuinely one of the more useful pieces of home health equipment for anyone over 60, or for anyone caring for an older parent. Here's how the check works. First, lie down flat and rest quietly for about 5 minutes. This part matters more than people expect. Your body needs that time to settle into a genuine resting state, not just a moment of sitting still after walking around the house. Once that 5 minutes is up, take your blood pressure while still lying down and write down both numbers. The top number called systolic pressure and the bottom number called diastolic pressure. Now here's the key step. Stand up. Not slowly and cautiously like you're testing the waters. Stand up at a normal, natural pace, the way you would if you were just getting up to answer the door. Within about 1 to 3 minutes of standing, take your blood pressure again. Write those numbers down too. Now compare the two sets of numbers. If you're systolic, the top number dropped by more than 20 points between lying down and standing. Or if you're diastolic, the bottom number dropped by more than 10 points. That's considered a sign of orthostatic hypotension. This isn't a strict pass-fail test you need to be anxious about. It's simply useful data. A drop within that range, especially if it happens consistently across a few different days, is worth bringing directly to your doctor. A few honest notes to keep this useful rather than stressful. First, do this test more than once, ideally over a few different days and maybe at different times. Once in the morning, once in the evening. Blood pressure naturally fluctuates throughout the day, and a single reading, even done carefully, is a data point, not a diagnosis. Second, if at any point during the test you feel genuinely faint or unsteady, sit or lie back down immediately and don't push through it. The point of this exercise is information, not endurance. And third, this simple home test is not a replacement for a full clinical evaluation. It's a tool to bring better information into that evaluation. Let's talk for a moment about why this particular test matters so much for older adults specifically, because the why makes the what to do much more meaningful. As we touched on earlier, the body's ability to quickly correct blood pressure when you change position tends to slow down with age. That means the dizziness some people experience isn't random or purely psychological. It often reflects a real, measurable physiological delay. And here's the part that deserves real attention. Unaddressed dizziness upon standing is one of the more significant modifiable risk factors for falls in older adults. Falls, in turn, are one of the leading causes of serious injury and loss of independence for people over 65. This isn't a minor inconvenience worth shrugging off. It's a pattern directly connected to some of the outcomes that matter most for quality of life as we age. Staying mobile, staying independent, and avoiding the kind of injury that can trigger a much longer decline. This is exactly why identifying orthostatic hypotension early is valuable. It's not about creating alarm over a normal part of aging. Plenty of people experience mild, occasional dizziness that resolves on its own and isn't a significant concern. It's about distinguishing that from a consistent, measurable pattern that a doctor can actually do something about. So what can actually be done about it once it's identified? This is where the conversation shifts from here's a problem to here's what typically helps. And this is worth understanding, even though every individual case needs to be assessed by a qualified physician who knows the person's full medical history. Sometimes orthostatic hypotension is connected to how and when blood pressure medications are being taken. For instance, timing adjustments, taking a medication at a different point in the day can sometimes reduce the overlap between peak medication effect and moments when someone is more likely to stand up, like first thing in the morning. Other times, it's about the combination or dosage of medications altogether, which is a conversation only a treating physician should navigate, since adjusting blood pressure medication without medical supervision can itself be risky. Beyond medication considerations, there are also everyday, low-risk habits that are commonly recommended for managing orthostatic symptoms, things like rising slowly and pausing briefly before walking, staying well hydrated throughout the day, and in some cases, adjusting how quickly someone gets out of bed in the morning by sitting on the edge of the bed for a moment first. These aren't replacements for medical care, but they're the kind of practical everyday adjustments that often get folded into a broader treatment plan. Here's a broader point worth sitting with. Blood pressure management for older adults has genuinely moved toward a more individualized approach over the past decade. Rather than treating every patient toward one universal target number, current medical guidance increasingly emphasizes tailoring targets based on a person's overall health picture. Their other conditions, their fall risk, their kidney function, how many medications they're already managing, and their day-to-day quality of life. This isn't a fringe or alternative viewpoint. It's reflected in updated clinical guidelines from major cardiology and geriatric medical organizations. What this means in practice is that two people of the same age with similar blood pressure readings might reasonably have somewhat different treatment approaches because their broader health context is different. That's not inconsistency. That's actually good, thoughtful medicine. And it's exactly why bringing detailed, specific information to your doctor, rather than just a single number, makes such a meaningful difference in the quality of care you receive. Now, here's where I want to bring this back to something practical and actionable, because understanding the why only matters if it changes what you actually do next. If you try tonight's test and notice a significant drop between lying down and standing, don't panic, and don't try to interpret it or self-treat based on what you've learned here. Instead, treat it as valuable information to bring into your next conversation with your doctor. Write your numbers down, note how you felt during the test, and mention any patterns you've noticed in daily life: dizziness in the morning, lightheadedness after meals, unsteadiness getting out of a car. These specific details help a physician distinguish between something that needs immediate attention and something that simply needs monitoring over time. In the next part, we're going to talk about exactly how to bring this conversation to your doctor in a way that gets a thorough, thoughtful response, including the specific questions worth asking: why just rise slowly often isn't the end of the conversation, and how to advocate for a more complete evaluation without ever stepping outside your doctor's expertise. We'll also talk about what happens for people caring for an aging parent who may not bring these symptoms up themselves. Let's talk about how to actually use everything we've covered so far, because information is only useful if it changes what happens in that next appointment. Here's something worth understanding about the doctor-patient relationship in a standard appointment. Physicians are almost always working within serious time constraints. A 15-minute visit has to cover medication reviews, other health concerns, any new symptoms, and often several unrelated topics, all before the appointment ends. This isn't a flaw in any individual doctor. It's simply the structural reality of how most primary care and even specialist visits are scheduled, which means the more specific, organized information a patient brings in, the more that limited time can actually be used well. So here's a simple, practical approach for your next visit. Bring your home blood pressure readings, both the lying down and standing numbers, from a few different days if possible. If you have a blood pressure monitor with memory storage, even better. Some models let you print or export a log. If not, a simple notebook or a note on your phone works just as well. Alongside those numbers, bring a short, honest account of any symptoms you've noticed. Does dizziness happen every time you stand, or only sometimes? Does it happen more in the morning or throughout the day? Does it happen after meals? Have you had any near falls or actual falls, even minor ones? These details matter more than people realize, because they help a physician distinguish between a mild, low-priority pattern and one that genuinely warrants a closer look or a change in approach. Then, when you're in the room, here are a few direct, specific questions worth asking. Based on my overall health and medications, is my current blood pressure target still the right one for me? This opens the door for your doctor to explain their reasoning and gives them the chance to reconsider it if your circumstances have changed. Another useful question. Given the dizziness I've noticed, should we check my blood pressure both lying down and standing at this visit? This directly requests the orthostatic check we walked through earlier, which isn't always part of a routine measurement. And a third, is there anything about how or when I'm taking my medication that could be contributing to this? These aren't confrontational questions. They're not designed to challenge your doctor's judgment. They're designed to give your doctor better information to work with, which is exactly what good patients and good physicians both want. Most doctors respond very well to a patient who arrives with organized, specific information, because it means less guesswork and a more productive use of a short appointment. I want to take a moment here to talk about something important. If you're reading this while caring for an aging parent or relative, this entire conversation applies just as much, maybe even more, to them. Older adults often don't report dizziness or unsteadiness clearly, sometimes because they've come to view it as a normal, expected part of getting older, and sometimes because they simply don't want to seem like they're struggling. If you've noticed a parent gripping furniture when they stand, pausing for a moment before walking, or mentioning offhand that they felt a little woozy this morning, those are exactly the kinds of details worth gently bringing up and potentially testing together, using the same simple lying down versus standing check we described. Let's bring together the core ideas from this video because there's a lot here and the takeaways matter more than the details. First, a single-seated blood pressure reading at a routine appointment doesn't capture everything that matters, especially for older adults. What happens to blood pressure during everyday position changes. Standing up from a chair, getting out of bed, is a piece of the picture that's often missed simply because it requires a different kind of measurement. Second, as the body ages, several physiological changes, including stiffer arteries, a slower internal pressure correction reflex, and shifts in how medications are processed, can make this standing-related blood pressure drop, known as orthostatic hypotension, more common and more consequential. Third, this is measurable, and you can check for it yourself tonight with a simple, low-cost home blood pressure monitor, following the lying down then standing method we walked through. Fourth, current medical guidance already supports individualized blood pressure targets for older adults, particularly those managing multiple health conditions or facing fall risk. This isn't a fringe idea. It's part of how modern, thoughtful cardiology and geriatric care already works. And fifth, the most valuable thing you can do with all of this is bring specific, organized information into your next doctor's appointment and ask direct, informed questions that invite a deeper conversation rather than simply accepting a single number as the end of the discussion. None of this replaces your physician's expertise, and nothing here should be used to adjust or stop any medication without medical guidance. What this does is give you the tools to be a more informed, more prepared participant in your own care, which, especially for something as nuanced as blood pressure management in older age, makes a genuine difference. If this gave you something worth trying tonight or something worth bringing up with a parent or loved one, consider sharing it with someone who might need it. Sometimes the most meaningful health conversations start with exactly this kind of simple, practical nudge. And if you'd like more straightforward, practical breakdowns like this one, subscribing means you won't miss the next topic we dig into. Thanks for spending this time here. Now go find that blood pressure monitor and see what your numbers actually look like tonight.